Well, good day, everybody. This is Chris with the Ancient Scholar. I hope this finds you all doing well today. It's been a little while since my last video. Been really busy here at work getting ready for a new semester. We have a really large class, a really large cohort that's starting their didactic phase, and so I'm going to be really busy there, and so we've been doing a lot of curriculum planning and whatnot. So I've been pretty busy, but I wanted to do another video talking about the Emergency Nurse Association conference that I did back in October. I know it's been a couple months, but this is yet another video on a topic that was covered that I found really compelling. It was really interesting and very relevant information. So without further preamble, let's go ahead and jump right into it. So what I want to talk about today is something called posterior stroke, or some people may refer to this as posterior stroke syndrome. And the interesting thing about posterior stroke syndrome is the traditional tools that we use to assess somebody of a suspected stroke are not as sensitive and specific for the presence or the absence of posterior stroke syndrome. There are some very unique findings associated with posterior stroke syndrome that are not well represented on the standard kinds of assessments that we do. So what's kind of the gold standard neurological assessment that gets done at some point in the care of a patient? Well, of course, that's the NIHSS, the National Institute of Health Stroke scale. But it's a comprehensive scale. It takes a while, and it's generally not done by anyone other than a physician in a more controlled setting, so it doesn't have the applicability to EMS providers, emergency room nurses, etc. However, and I believe this is in the late 80s when this scale was developed, and then in the late 90s, I think around 96, 97, some specific components of that were extracted out, and that became known as the Cincinnati Pre-Hospital Stroke Scale or scoring system, the CPSS, and this is the classic. Are you looking for facial droop? Are you looking for arm drift? You have the patient say, you can't teach an old dog new tricks, right? These are just standard things that everybody pretty much learns, and these are kind of the standard things that we'd use to assess patients. But there is this syndrome, and it's approximately 20% of all stroke patients will have a posterior stroke, and it's not well represented. What can happen with posterior stroke is not necessarily well represented in, say, the CPSS, and there's the fast scoring system in these kinds of things. And again, it might be easy, particularly in a pre-hospital environment where you're assessing somebody, it might be easy to miss some concerning findings. So let's talk about posterior stroke syndrome. And first of all, I just want to talk about the coarse grain way that the brain gets its perfusion. And this is maybe an aside from this discussion, but it's still relevant material. So basically, your brain gets perfused, two major sources of perfusion. It has an anterior, or it gets perfusion blood flow from the front, and posterior from the back. And from the front, it's the common carotid arteries branch out into the internal carotid arteries and the external carotid arteries mainly feed the face, the scalp, and extra cerebral structures of blood, whereas the internal carotid arteries feed into a structure collectively known as the circle of Willis. Internal carotid arteries go in, and then they feed primarily perfusion to the anterior cerebral artery, the middle cerebral artery, right? And a lot of the perfusion of the frontal lobe, the parietal lobes, right here in the front of the brain. Well, you also have what are called your vertebral arteries, and the vertebral arteries come off of the subclavian arteries, and then they're a little forama in your cervical vertebrae, and those vertebral arteries come up from those vertebrae, and they go in to the posterior part of the brain, and they come together to form the basilar artery at the base of the brainstem, and that feeds the brainstem, the pons, the medulla, and then you have little pontine arteries that come out of that, and then you have the cerebellar circulation and the posterior cerebral arteries that come out of that, and then it comes and wraps around and connects into the circle of Willis, and you have some crossover between anterior and posterior. So when you have posterior stroke, you have a compromise to this posterior perfusion mechanism, which means what? Which means very different areas of the brain are impacted, right? Where more classic strokes tend to involve, the motor cortex, can involve the frontal part, the prefrontal cortex, and so they can involve behavior, it can involve speech, it can involve movement, and you can get classic, speech problems, you can get classic neglect, you can have contralateral neurological problems, right? Or you have a flaccid arm, and you get that classic arm drift, and it tends to be it tends to involve one side of the body, and it tends to be contralateral to where the deficit in the brain is, right? These are more classic things. Well, but posterior stroke, because we're dealing with different structures, you're dealing with the occipital lobe, you're dealing with the temporal lobe, you're dealing with the cerebellum and the brainstem, you can get some very different findings, and let's go ahead and just talk about these different findings. So first of all, sudden onset visual deficits. If somebody has a sudden onset visual deficit, that should be a red flag that potentially posterior stroke is involved. And there are many other things that sudden onset things that can also manifest with sudden visual changes. Retinal detachment might be one of them, right? So you kind of have to parse that out. But sudden visual change is a red flag, right? That's a big one. And there are some, just think of D's, the standard D's of posterior stroke. Sudden onset dizziness. And dizziness is a very vague, non-specific finding, but it tends to be kind of like non-paroxysmal dizziness where it just doesn't go away. It's just constant, it doesn't go away, it doesn't necessarily have a positional component to it. And a real positional component tends to be more characteristic of benign postural BPV, benign postural vertigo, and things like that. Whereas this is sustained disequilibrium, right? They have sudden sustained loss of balance, dystaxia, and how can we assess dystaxia? Have the person, can they bring their finger up to their face or their nose, and they'll bring it in, poke their eye, and they'll have that discoordination there, dysmetria, diplopia, right? These weird pupillary changes, and sometimes you can even get bilateral pinpoint pupils, right? Which is very different, right? That's bilateral pinpoint pupils tend to be associated with a stroke in the pontine area or pontine stroke, and other things can cause this too, right? Opioid exposure. So you need to kind of parse that out as well, the best you can. Dysarthrias, right? Cranial nerve problems are very common. Dysphagia as well tends to be something that we can see in these patients as well. So there you have it. So let's talk about. So you got some weird signs and symptoms that are more specific, and let's talk about diagnosing this from a radiologic or special procedure standpoint. About 20-50% of posterior strokes are initially negative on CT scans. So CT scan's not, and in general, a CT scan is not great for ischemic strokes, and we really don't do a CT scan on a suspected stroke to detect ischemic brain, but rather to detect or differentiate a hemorrhage, right? Is this hemorrhagic or non-hemorrhagic? What is it about? It's about 15% of strokes have a hemorrhagic component, 85% are ischemic. So we want to, because there are specific interventions that might be done involving fibrinolytic agents that might impact the recovery and the subsequent clinical course of the patient. So it's important to identify the presence or absence of a hemorrhagic component. MRI, you might think magnetic resonance imaging might be a better exam to do, False negatives are very common the first 2 days of posterior stroke. So posterior stroke is often going to be initially a clinical diagnosis. That's really important, right? It's going to be history and physical exam, signs and symptoms, marrying that together to create a differential diagnosis that suggests posterior stroke, right? So there is something called the BFAST scale that's out there that is specific to posterior signs and symptoms. You look at the balance, you look at the eyes, you look for asymmetries in the face, you look for arm weakness, arms hanging down, you look for speech problem, you look about time, and within the eyes I'd also throw in a visual component to that as well. So what are some other things that increase the suspicion of posterior stroke? Obviously sudden onset, right? If somebody has gradual onset of visual changes, this is more suggestive of other types of pathology. Non-paroxysmal, so sustained, right? Sustained dizziness. Dizziness doesn't have a motion component, it's just always there, it doesn't get any better. Obviously, a history of atrial fibrillation substantially increases the risk of stroke in general. Hypertension, dyslipidemia, lipid disorders, so elevated lipids, hypercholesterolemia, those kinds of things. And there are some very unique things that can happen too, and this is going to be really important for us to understand. There's something called locked-in syndrome. And this is where you have a patient that has preservation of higher cerebral function, right? Personality, thinking, cognition, planning. These things are preserved, but due to the posterior stroke impacting the pathways, right? The impacting the ability for these higher brain functions to control the body, that you have a patient who is alert, awake, oriented, conscious, but virtually incapable of communicating that to the outside world. So you have a patient who clinically appears to be in a vegetative state. They appear to be non-communicative. They appear to be not able to have any higher function, but in fact they do have high function. And oftentimes in the setting of locked-in syndrome, these patients are going to have some very subtle very subtle capabilities in terms of eye motion. They may be able to move the eye up a little bit, right? And so when you're assessing somebody and maybe they appear to be unresponsive, right, really carefully assessing eye motion, right? Talking to that patient and saying, if you can hear me, can you move your eyes up, right? And then you look at their eyes and a little subtle motion, right? That may push you in the direction of oh, this might be somebody suffering from locked-in syndrome, right? And there are some interventions that we can do that are not going to, substantially help this patient, but what they're going to do is they're going to enable this patient to actually communicate, right? And this could be very important. This could be a life-changing kind of thing, and clearly it's disastrous if it goes unnoticed. And some other things that can happen with posterior stroke in particular, but strokes in general, is you can get something called cytotoxic edema. This tends to be more common in posterior stroke simply because the area where this happens is already kind of tight. There just is less capacity for swelling to occur there, so a herniation, hydrocephalus, those kinds of things tend to be actually a little more pronounced, a little more common in the setting of posterior stroke. And this is ischemic stroke, right? Where I'm not even talking blood, I'm just talking edema edema due to cell death, right? Due to kind of the normal apoptosis and necrosis that occurs in the setting of significant cerebral ischemia in this area. The posterior tends to be a little more sensitive to the edema. So there you guys go. Hopefully you found that kind of interesting. Let's just talk about some general treatment, and this is just for stroke in general, right? Head of bed up, right? If you can, you want these patients upright a little bit. That helps increase venous drainage. You can help with aspiration, airway management, those kinds of things. Hyperosmolar therapy may or may not have a role. Things like mannitol, bicarb, 3% saline. Definitely monitoring and maintaining an acceptable mean arterial pressure. Sedation may be helpful. You know, if they end up having significant swelling, do they need a ventricular drain placed for hydrocephalus or burr holes? Those kinds of things. And just remember, fibrinolytics might have a role to play in these patients, you know, particularly if it's sudden onset and you can get a rapid door to needle time of, even down to 45 minutes. You may have subtle improvements, but these subtle impacts can really have significant impacts when you look at somebody's life as a whole. There's a whole big debate that can be had around fibrinolytics in general for ischemic strokes, and I don't really want to get into that here. I just really want to focus more on posterior stroke and more on the unique characteristics of posterior stroke that separate it from the more traditional stroke syndromes. And so we might need to be a little more nuanced in how we assess suspected stroke patients, particularly in the emergency setting and the pre-hospital setting where things can get overlooked fairly easily. So hopefully you guys found this video helpful, and hopefully you find this information relevant to your clinical practice. All right, guys, as always, thanks for hanging in there.